It's my pleasure to introduce next speaker, Professor Inass Shaltout, Professor of Endocrinology and Diabetes, and the President of the Arab Association of Study of Diabetes and Metabolism. It's our pleasure to have you with us today, Professor Inass, and she will give us very interesting talk about the insulin resistance and hypertension. What's new?
Bismillah ar-Rahman ar-Rahim. طبعا my pleasure and honor to be with you today. شكرا للدعوة الكريمة أستاذ دكتور محسن إبراهيم والأستاذ دكتور سليمان غريب. الحقيقة لما اتكلفت بالتوبيك ده ابتديت أفكر يعني this topic is not new بس إيه ممكن يكون جديد في hypertension relation with insulin resistance. And I found this update in a new topic, which is sarcopenia. And sarcopenia is a Greek name, which means lack of flesh. Sarcopenia is a newly recognized geriatric syndrome. It is age-related loss of muscle mass and muscle function. Studies confirmed the association between sarcopenia and adverse health outcomes, for example, falls, disability, hospital admission, long-term care placement, poor quality of life, and increased mortality. And these findings denote the importance of sarcopenia in health care of older individuals. This is a loss of muscle mass and strength with aging, and this graph is showing the percentage of muscle loss with aging, comparing those at the age of 25 to those at the age of 45 to those at the age of 75, and the percentage of muscle loss is increasing by age. After the age of 50, there is 1 to 2% loss of muscle mass per year. After the age of 60, the loss of muscle mass increases to 3% and loss of muscle strength of 1.5% annually. These are the changes in body composition associated with aging. They include gradual decrease in muscle mass, especially in lower extremities, and increase in fat volume, especially visceral fats, and we have a main concern of visceral fats with insulin resistance, and loss and increase in fat volume intramuscular. The prevalence of sarcopenia, depending on the definition used for diagnosis, the global prevalence range from 10 to 40% of the world population, and increasing lifespan led to increased number of persons above the age of 65, led to increasing of age-related conditions such as sarcopenia, diabetes, and hypertension. And globally, individuals above the age of 65 in 2022 were 9% of the total population, and expected by 2050 to be 16% of the total population, with roughly number of 1.5 billion elderly person. This is the 2018 operational definition of sarcopenia. Criterion 1 means low muscle strength. Criterion 2, low muscle quantity or quality, and criterion 3, low physical performance. And if there is only criterion 1, there is probable diagnosis of sarcopenia. And diagnosis is confirmed by additional documentation of criterion 2. If criterion 1, 2, and 3 are all met, then sarcopenia is considered severe. This is the pathophysiological defects leading to sarcopenia: decreased physical activity, endocrine factors, muscle atrophy, decreased protein synthesis, insulin resistance, mitochondrial dysfunction, autophagy, and malnutrition. It is a multifactorial disorder, decreased level of sex hormones, testosterone and DHEA, decreased level of growth hormone and insulin-like growth factor 1, increased cytokine production, interleukin-1, interleukin-6, and tumor necrosis factor, neuromuscular changes, smoking, physical inactivity, and malnutrition, especially protein deficiency. The changes in muscle function in sarcopenia, there is preferential loss of type 2 muscle fibers leading to difficulty in walking, stair climbing, rising from chair, gait problems, and load carrying deteriorates. Loss of independence, increased risk of falls, decreased basal metabolic rate, leading to what is called middle age overweight. There is decrease in lean muscle mass associated with increase in total lipid stores by age. And this is a comparison between those at the age of 20 to those above the age of 70. There is loss of muscle mass and increased fat stores. And this is also the muscles before and after sarcopenia. After sarcopenia, we're going to have loss of muscle mass and increased fatty tissue. But sarcopenia is not wasting. Wasting means loss of weight due to inadequate nutrition. Sarcopenia is not cachexia. Cachexia is loss of fat-free mass from hypermetabolism and hypercatabolism. While in disuse atrophy, the muscle mass is reduced, but fiber numbers and force is maintained. Diabetes can cause sarcopenia, and type 2 diabetes is characterized by insulin resistance, chronic inflammation, accumulation of advanced glycated end products, and increased oxidative stress. They can negatively affect skeletal muscle mass, strength, and function, leading to sarcopenia. How does diabetes affect the muscular system? Compared to non-diabetics, diabetic patients have decreased muscle mass and higher prevalence of sarcopenia. Patients with sarcopenia may be at increased risk of developing diabetes. How does insulin resistance cause sarcopenia? Insulin resistance plays an important role in sarcopenia pathogenesis by inducing muscle attenuation, by increased protein catabolism, and decreased protein synthesis in the skeletal muscles. Several papers established a reciprocal relationship between diabetes and sarcopenia. Sarcopenia prevalence is 2 to 3 times increased in the presence of diabetic patients, and also vice versa. Several factors have been implicated in this relationship: insulin resistance, altered metabolism, advanced age, increased adiposity, inflammation, oxidative stresses, ages, mitochondrial dysfunction, vascular complications, muscle atrophy, reduced muscle quality and function, myopathy, and lifestyle in the form of poor exercise and diet. This is showing the relationship between sarcopenia and diabetes. And is there a relation between sarcopenia and hypertension? And hypertension is a major public health problem in developing countries. Hypertension is highly linked to insulin resistance, which exacerbates the loss of muscle strength. Insulin resistance contributes to hypertension through several mechanisms. Enhancement of tissue angiotensin II and aldosterone activity, increased sympathetic nervous system activity, oxidative stress, and a new phenomenon known as endothelial insulin resistance. This study was published in July 2022 about the prevalence of and factors associated with sarcopenia among elderly individuals with hypertension, and the overall prevalence of sarcopenia among elderly individuals with hypertension was 20%. And these factors were highly significant in those above the age of 70. The study diagnosed sarcopenia by the presence of low muscle strength, defined as hand grip strength, and low physical performance, defined as gait speed, low gait speed. Those above the age of 60, hand strength or grip strength and walking speed were assessed. If normal, then there is no sarcopenia. If low grip strength and or low walking speed, we measure the muscle mass. If normal, there is no sarcopenia. If low, there is sarcopenia. The discussion of this study, the study found a very high prevalence of sarcopenia among elderly individuals with hypertension, 20%. But recent systematic review estimated the overall prevalence of sarcopenia is 10% in adults above the age of 60. Current research confirms sarcopenia is associated with hypertension. The possible mechanism, hypertension can lead to production of catabolic cytokines. Chronic inflammation associated with catabolic factors remain the most widely accepted mechanism of sarcopenia. The results of this study showed that age was associated with higher risk of sarcopenia, muscle mass, and function decline with age, but this can rapidly progress in the setting of chronic conditions like hypertension. This is possible mechanism correlating sarcopenia with cardiovascular disease. Both can be affected by malnutrition, physical inactivity, insulin resistance, inflammation, hormonal change, autophagy, apoptosis, and oxidative stress. So there is a link between sarcopenia and cardiovascular disease in the form of heart failure, hypertension, atherosclerosis, and coronary heart disease. This needs to be more elucidated, and sarcopenia, there is potential health concern. Rates of decline in strength are twice as high in men compared to women, and men on average have a heavier or larger amount of muscle mass, and men have shorter survival than women. Let me finish by the treatment of sarcopenia, which can be preventive. Regular exercise from early life can be preventive to sarcopenia. And later on, we can do resistance exercise to prevent or reverse the muscle loss. Aerobic activity, walking, cycling, golfing, and swimming. Lifestyle modification, nutritional modification, protein, carbohydrate, and fiber. Stress-free environment whenever possible, and functional and active daily schedule. Thank you very much.
Thank you, Professor Inass. It's an excellent presentation and a lot of new data and new information for us as cardiologists. Any question from the floor? Okay, I will take this opportunity for just a small question. We heard in the last few decades without evidence, about something called coenzyme Q capsules and tablets, which could potentially improve the muscle performance. Any evidence regarding sarcopenia, especially in cases of insulin resistance, for these coenzyme Q capsules?
I need to do a research. I'll make a research or search and let you know. I don't know.
Okay. Thank you so much. Thank you.